Hello everyone, myself Dr. Nisarg Desai. I am Assistant Professor in Department of Cardiology at UNMICRC. So today's topic is how to assess the myocardial viability. On what principles the viability, on what principles the test used to assess the viability work, and what are the various clinical applications that we can get with those tests. So first of all, we need to understand what is viability. When we say that myocardium is viable, it is in simple terms, it means that myocardium is alive. Now there are various aspects to it that will be discussed in the subsequent slides. So as I said, myocardial viability refers to the ischemia-induced dysfunctional myocardium that is still alive, it is not irreversibly damaged, and if the blood supply is restored with revascularization, the contractile reserve, the contractile function of the heart may recover. That is the basic crux of what is meant by myocardial viability. So once we talk about viability, no discussion is complete without differentiating what is stunned myocardium versus hibernating myocardium. So again, just to recap it, a myocardium that has potential for functional recovery with revascularization is a viable myocardium. It can be of two types, a stunned myocardium versus hibernating myocardium. The point to highlight here is the resting flow. The resting flow is the only thing that is actually differentiating between the stunned and hibernating myocardium. In stunned myocardium, let's say a patient comes with an anterior wall MI. That is a brief ischemic insult, which may have lasted for a few minutes to hours. So for that patient, his myocardium is stunned. His resting flow was normal. It is an acute MI. However, in hibernating myocardium, when there is, let's say, a patient who is a smoker, 40-year-old male, has a triple vessel disease with a decreased resting flow and is subjected to chronic ischemia, that contractile dysfunction can still recover, but the differentiating feature between stunned and hibernating is this patients will have reduced resting flow as well. So with the diagrammatic representation, we will see in the next slides as to how a stunned myocardium progresses to a hibernating myocardium, or a hibernating myocardium progresses to a scar tissue and a non-viable myocardium. So this is a brief summary. We will focus on the second part, this thing. What is the contractile reserve in each case? So once the myocardial ischemia starts, if it is transient or temporary, it is a stunned myocardium, and the contractile reserve, metabolism and perfusion is still maintained, let's say for a few hours to days. But if it is progressing chronically, as I said, may go to hibernating early, late, and myocardial scar. The probability of recovery is 100% in an acutely stunned myocardium. However, it progresses to almost zero if it is a myocardial scar. So how to assess when a patient comes to you, based on the clinical findings, history, ECG, echo, as to how a patient will behave, whether revascularization for this patient will help or not. If we are planning a revascularization, what strategy should be implemented, and likewise, that will be discussed in the coming slides. So as I said, on the y-axis, this is the percentage of normal, and this is the time duration. Percentage of normal is, and in the blue, in the red, it is the myocardial contractile function. Blue is the coronary blood flow. So as soon as here there is an ischemia going on, so in minutes, as the ischemia sets in, the myocardial contractility as well as the coronary blood flow both drops. But point to be noted here is, even if we restore the coronary blood flow, let's say after revascularization, thrombolysis, whatever strategy that we adopt, the blood flow may return back to normal, but the contractile function still takes some time to recover. Maybe it may be days to weeks, depending on the amount of myocardium that is involved. The difference between a stunning and a hibernating myocardium is that the ischemia lasted for minutes. Here it is a chronic ischemia. We must observe that the resting flow is also reduced here, and still the myocardium is viable because it has not been completely scarred, and once revascularization is there, it will also recover. But how to decide whether a myocardium will respond to revascularization or not? For that, we have various viability tests. So that will be seen in the next slides. Again, just the continuation of it. First, we'll understand what is on the y-axis and what is on the x-axis. So x-axis is the time. Here it is in figure A, it is soon it is 24 hours, and the dotted line here is the ischemic threshold. So once a brief ischemia, the black line is the resting flow. So even if small amount of ischemia occurs, myocardial oxygen demands increases in a very little manner, so it crosses the baseline, it crosses the threshold. So even small amounts of ischemia leads to repetitive stunning, and as we can observe that repetitive stunning, gradually the myocardial contractility goes down. This is for hours, and the same thing is getting repeated over weeks to months. So this stunned myocardium is now progressing to a hibernating myocardium with a diminished contractile reserve, but it is, if the tests are suggestive that there is still viability left, revascularization may improve the contractile reserve as shown in the figure C. The point being here is that even small amount of ischemia in a patient who has critical stenosis or low ischemic threshold will lead to repetitive stunning. That is the main crux of the figure A. This is just the repetition. We want to differentiate. Why we are assessing the viability is because we want to differentiate whether the LV dysfunction is reversible or not, whether there is a contractile reserve left or not, and what is the prognosis after the revascularization of this patient. And if the prognosis is poor, whether the patient is a candidate for heart transplant or end stage heart failure management if it is a non-viable myocardium. So we'll divide the utility of the viability assessment in following headings: coronary artery disease, heart failure, and even in valve disease. So if the patient has, let's say he has 70-80% single vessel disease, and let's say left anterior descending artery shows 70% to 80% disease, then viability in this patient is more of a it's more of a stress based assessment. But if it is a single vessel disease and it shows, let's say LAD is totally occluded, then the myocardial viability will allow us to assess whether the revascularization will help or this patient needs a medical management itself. So coming to it, once we have decided that okay, the patient needs myocardial revascularization, will benefit from revascularization, then depending on the amount of myocardium that has been involved, whether the patient will benefit from simply stenting, or if the large area of myocardium is involved, then patient needs CABG. So that can also be assessed by those tests. If the CTO has got very less of collaterals or the myocardium is non-viable, then revascularization strategies will not help. That will be also given by myocardial viability test. Another thing is ischemic mitral regurgitation. If the myocardium is scarred, the asymmetric MR may not improve even after revascularization of a given territory, for example left circumflex. So that patient will benefit more from CABG as well as a mitral valve repair. So another thing is a low flow, low gradient severe AS. So this test will indirectly help us to differentiate between true AS, true aortic stenosis versus pseudo severe aortic stenosis. If the LV dysfunction is very severe and the gradients, the area that we achieve is less than 1, but the LV dysfunction is very severe and a scarred territory, a non-viable, non-ischemic cardiomyopathy that is being shown on the various tests that we'll be discussing in the subsequent slide, then the patient has got probably pseudo-severe AS and does not need a aortic valve replacement. He probably needs some medical management. Another thing to understand is the prediction of a CRT response. So CRT is basically, we are putting 3 leads. The third lead, RA, RV and the LV lead. So the LV lead, if we are putting and if it is in the scarred myocardium, the patient will not be a CRT responder. So that also can be assessed. Even the scar burden will help us in risk stratifying the patient, whether he is a appropriate candidate for AICD or not. The studies are going on to know the exact cutoff, whether more than 15-20% myocardium that is scarred and the patient has got a ischemic or non-ischemic cardiomyopathy, at what cutoffs the AICD can help. So those studies are going on. Even in EP planning it will help. So this is the broad spectrum where myocardial viability assessment will help. So coming to a case-based discussion, is a 45-year-old late presenter. This is the ECG taken at 7th day of anterior wall MI patient who is in Phillips class 2 at present in severe LV dysfunction. EF is 30%. So as we can see in this ECG, there are QS complexes in the anterior leads and there is persistent ST elevation in V1 to V3, P1 to V4, suggesting that the myocardium might not be viable. It may be aneurysmally dilated, and so this is ECG also itself is a very good test to demonstrate whether the myocardium is viable or not. But to secure our diagnosis, we need objective evidence in the form of echo or nuclear scan or MRI. So basically this patient we can opt for any of this. So this is the ECG finding as stated, that has got poor R wave progression, persistent ST elevation and QS complexes with no ST resolution. So his viability can be assessed with any of these parameters. The sensitivity and specificity of each of is different. To understand the sensitivity and specificity, we need to understand the principles on what they work and what are the drawbacks amongst those tests. So we'll start off with echocardiography just to brush up the territories that are involved. So this is the 4-chamber view. The red one is showing the LAD or L6 territory. The blue is obviously RC and the green one is the LAD territory. So this is the 4-chamber. Similarly, apical 2-chamber and a long axis plex view. So from the labeled headings, we can just know which territory is involved. So how do we assess for ischemia? So we need to check for the amplitude of contraction. What is the velocity of contraction and whether there is delay in the onset of a given territory as compared to the remaining territories. So that is known as tardokinesis. And after all of this, is there any post-systolic contraction in a given territory or not? So in this case, on echo we found that the LAD was apically aneurysmally dilated and there was post-systolic contraction seen in those areas of LAD. So what are the markers of poor revascularization in echo? Whether if the end diastolic wall thickness is less than 6 mm or the end diastolic volume is more than 130 ml. They are the poor prognostic revascularization outcomes. These patients will benefit more from medical management over revascularization. Another thing is to look for whenever we are, as discussed, whether not for this patient but for the patient, we want to see whether the patient has got a hibernating or a stunned myocardium or whether basically it is viable or not. We need to give dobutamine stress echo, but it's always a low dose. The dose is between 2.5 to 10 micrograms per kg per minute, and what we see is any of these 4 responses. whether there is a biphasic response, that is on low dose the myocardium may not contract, but on increasing the dose slightly from 2.5 to 10, there is slight increase in the myocardial contractility. That's suggestive of viable myocardium. And if there is no response, it is basically a scarred tissue. We will see it in the coming example. So this is a biphasic response. We need to focus on the red curvilinear area. You can see that at no dose it was the curvilinear area is less, but as the dose of the dobutamine is increased from 2.5 over 10, you can see that there is increase in the curvilinear area, there is improvement in the contractility as shown in figure B and C. And at very high doses, at higher dose, which was at 40 microgram, there was the apical segment actually showed thinning and akinesia, but that is because of high catecholamine. So this is a biphasic response. This is at low dose, which shows less curvilinear area, but as the dose increases, the curvilinear area increases and there is improvement in the contractility. This is a basic biphasic response. Sustained response for a non-ischemic dilated cardiomyopathy with a preserved stroke volume index. Again the same thing, there is improvement in the curvilinear area as the dobutamine dose increases, which is a good prognostic marker. And this is a scarred tissue despite increase in dose. There is no improvement in the dotted curvilinear area. So one thing to note is that contrast echo helps in better delineation of the endocardial surfaces. Strain imaging, again the same thing. This is the polar map which shows that at stress the territory which is preserved is a basal one. This is the territory that is preserved at basal one. The apical, anterolateral area and the infralateral areas are all ischemic and probably non-viable. So next that comes is the nuclear scan. The crux of nuclear scan is whether the patient, so in nuclear scan there are two main modalities, the SPECT and the PET scan. For a viable myocardium there has to be an intact cell membrane or an intact transport mechanism. We will study as the radioisotopes that we use, and depending on that it requires either an intact cell membrane or an intact transport mechanism. So what is the principle? There are radio-labeled drugs which are injected intravenously that get trapped in myocardial tissue. The radioactivity within the heart decays by emitting the gamma rays, and those gamma rays are picked up by the specialized detectors and scanners, SPECT or PET, and which creates a scintillating image or light output, which can be captured by digital recording, and where we can form an image. Basically here we want to discuss that which are the various agents, whether it is a technetium, tetrafosmin, and there are various, these are the agents for SPECT, whereas there are rubidium, ammonia and FDG are for the PET, and there is the half-life is variable. To understand that, PET scan is basically a perfusion imaging, and so we will discuss how it exactly works. We will see in the next slide. So again, where does the nuclear scintigraphy help? It helps in assessing the infarct size, differentiating between stunned and hibernating myocardium, and what is the amount of inducible ischemia in a case of a multivessel coronary artery disease, left ventricular volumes and function, and even it helps in the denoting what is the coronary blood flow reserve. So those things can be assessed with nuclear scintigraphy. So coming to the first scan, SPECT scan, let's focus on the middle part, this thing. So as we can see that this is a thallium scan, and there are two main properties that thallium has, which will be differentiating it from the technetium. So what we do is we do an initial imaging with thallium. The areas which have got decreased perfusion will show decreased uptake. And this redistribution imaging, which is seen with thallium only, is that thallium washes out of the normal tissue, but it re-enters the hypoperfused but viable myocardium. So as we can see that as the time goes by, thallium is redistributing itself in these areas. So this is the at rest, which is showing lack of perfusion, but as the time goes by, the hypoperfused areas start showing up. So with thallium, which is not the case when we use another agent, another radioisotope, technetium. So initially the dark area becomes brighter, so that is suggestive of a viable distribution. But to note that this lateral territories were viable, but the inferior one, it was at rest, it was not showing up. Again after some time, the other areas were showing up, but it kept on. There was no redistribution in those areas, inferior areas. So this is basically an inferior area is scarred, but the anterolateral areas, they are still good, and this territory of the heart will benefit from revascularization. So if there is a double vessel disease, we can decide as to what territory will help the patient improve outcome and prognosis. Again, as I said, technetium, there is no redistribution. Technetium scan is not a good test for viability assessment. Why? Because it depends on the myocardial coronary blood flow. If the coronary blood flow is reduced, the uptake is reduced. Even if the myocardium is viable, the coronary blood flow, if it is reduced, and as there is no redistribution phenomena, we can underestimate the viability. So in those cases, myocardial viability is better assessed with either thallium or other tests like MRI. The only drawback of thallium is it is difficult to store. It is a bulky molecule, and second thing is the half-life of thallium is very high as compared to technetium. So post radiation exposure, the patient can still emit the radiation, and that is why thallium is no more in use. Technetium is being used, but it's not a good test for viability assessment. And why is it that there is no redistribution in technetium? Is because in thallium is transported via sodium potassium uptake, and mitochondrial dysfunction is the first to go when there is ischemia. So sestamine uptake, it depends on the mitochondrial membrane potential. So in particular, the myocardium uptake may be blunted because there may be initial mitochondrial dysfunction as soon as the ischemia sets in. So just because they are transported through different routes, the outcomes are also different. And okay, so this is a busy slide, but we just want to focus on figure B. So we have discussed the nucleus, the SPECT scan. We are now taking the discussion to PET scan. But the most important thing to remember here is that no PET scan is complete without a metabolic preparation. The underlying test is basically depend on how well you prepare the patient. If the patient is not metabolically prepared well, the results can be either false negative or false positive. So why is it that why is it that we'll study in the next slide. So basically, as shown in figure B, we'll first take the rest scan. Then here we are injecting the either IV FDG. FDG is a fluorodeoxyglucose molecule which is based on the perfusion. But before giving that, we are giving either oral glucose or IV insulin infusion. And why is it that? As we will see that heart uses a dual substrate. In fasting or when the patient is given high fat diet, it uses the free fatty acid. Once the patient is fed or is on insulin, the myocardium has got a glucose as the main metabolic parameter. This is a very important slide to understand. At fasting or high fat diet, the myocardium will take up free fatty acid. Once the patient is well fed or insulin or even given glucose, he will start utilizing the glucose. Now, what is the purpose of preparation in viability? when we are assessing the viability is we want to shift the myocardium to glucose utilization from the free fatty acid. And what insulin or glucose administration does is it helps in the uniform uptake. So from the free fatty acid, we are shifting the myocardium to a glucose utilization phase. And what an insulin infusion plus a glucose co-administration does it leads to a more uniform uptake, which helps in better viability demonstration. Whereas on the other end, when we are preparing the patient for a metabolic to assess the inflammatory cardiomyopathy, for example, sarcoidosis or tubercular myocarditis, or any inflammation, any myocarditis for that reason, we want to turn off the physiological myocardial glucose uptake. Why? Because when we give high fat or low carb or low glucose diet and followed by prolonged fasting, this helps to shift the myocardial cells to switch to free fatty acid uptake. When we give a high fat diet, as we were discussing previously, the high fatty diet, the myocardium starts utilizing the free fatty acid. So the areas that are normal, non-involved in the inflammation, they will turn dark. But once we give 18-FDG, the radioactive glucose molecule, these inflammatory cells, leukocytes and various other inflammatory cells will still require glycolysis as the metabolic activity in those cells is very high. So they will utilize 18-FDG, whereas the normal cells, they will shut off taking the glucose and will switch to the free fatty acid metabolism. So that is the main mechanism. Those areas that are normal will not use glucose, they will turn dark. Those areas which are dependent on glycolysis, they will keep taking up the glucose and they will light up when we do the PET scan. So this is one more thing to understand, what is the difference between matched versus mismatched defects. So these are this we'll see the figure 1 and 2 here, the left side of the figure. As you can see that there is perfusion defect in both hibernating and scarred myocardium. The wall motion is abnormal in both of them, but the uptake with 18-FDG is increased in an hibernating myocardium. See, the area is dark here. As soon as the 18-FDG is introduced, it takes up that because it is viable. So that area is viable, so it takes up. So on rest, there is no uptake. On 18-FDG, there is uptake. So this is mismatch defect. This is the mismatch that we want to see, and if it is there, the revascularization will help a patient. If there is no uptake even on 18-FDG, even after giving 18-FDG, this is a match defect from baseline as well as in the after the nuclear scan. So it's a match defect, and match defects usually suggest scar tissue. Sometimes there can be a reverse mismatch defect, that is uptake will be there normally, but when we give 18-FDG, the uptake will go away. Those things are because of conductions, left bundle branch block or conduction system pacing, a pacemaker dependent thing. So these are rarely found, but the main difference to understand is a mismatch versus a matched defect. Matched defect means patient will not get help from the revascularization. So one thing to understand is focal uptake. So we'll see the second figure. We'll see this, the middle column. You can see that usually after giving, this is at the baseline, the perfusion is good everywhere, but once we give 18-FDG after proper diet preparation, the areas that are taking high fat, they will turn black, they will turn dark, but the areas that are still having high inflammatory activity, they will keep showing focal uptake because of the continued glycolysis and requirement of 18-FDG in those areas. So that's it. That's it about the nuclear scan. Now we'll focus on another sophisticated modality of imaging, that is cardiac MRI. As discussed, the sensitivity and specificity of each one of them varies and we'll understand why. Because of the modalities, the principles that are involved in capturing those images, the sensitivity and specificity is different. What helps in cardiac MRI is it characterizes a suspected hibernating myocardium by combination of techniques, that is end-diastolic wall thickness, the contractile reserve function is there or not, and based on the LGE assessment and what is the transmural extent of the involvement of the infarction. So what is the principle? We use gadolinium based contrast. They shorten the T1 relaxation time of the surrounding tissue proportional to the local gadolinium concentration. What is important to understand is the GBCA is not able to unable to cross a normal myocyte, but once the myocyte cell membrane is damaged, as in case of acute MI, or if there is an increase in the interstitial matrix or the extracellular space, it starts accumulating in those areas. So the areas that are infarcted, fibrotic, inflamed, or infiltration, all those things will be taken up by the GBCA. All those tissues will take up GBCA and will show up on imaging in the T1 weighted imaging. Again, what is the difference between acute infarct, a chronic infarct, and a hibernating myocardium is when we take the cine image, an acute infarct can be akinetic or hypokinetic. Chronic infarct will show, in addition to it, a thinning or LV apical aneurysm or basically a dysfunction. If it is a hibernating myocardium, it will show dysfunction. But what is important to understand is, hibernating myocardium will not have an LGE. An acute infarct can still have LGE because the myocyte is still damaged, the cell membrane is damaged. So having an LGE on MRI does not necessarily mean it is a chronic infarct. T2 and T1 imaging in acute versus chronic is important because the structures that are bright on this imaging, T1, T2, will not be seen with chronic infarct. We will see with examples that the brighter tissues means acute infarct in T1, T2, and chronic infarct does not have a T1, T2 uptake. So this is a figure again. What we can see here is in the above panel, there is a reduced thickening in the systole in the inferior segments. So this is the thickness, but once if you see carefully, there is decreased thickening in the inferior segment, and there is hyper enhancement in the inferior areas in acute infarct, which will not be seen with chronic infarct, and that is explained in the below figure. What is important to see is that there is an LG in the inferior segments, which is suggestive of infarction. And as stated, if it is a chronic infarct, T2 weighted images will not be bright and LG will be easily discernible in this. The whole idea of this was to see that the T1 versus T2 weighted images, LG can be there in both acute as well as chronic infarct as well as in the scar tissue. So this is the cine image that we were describing. So in left side of the figure, we can see that there is delay of the this wall as compared to the LED. The LED territory shows delay as compared to the inferior segments, and we can see here that there is some apical ballooning or some sort of aneurysmal dilatation in the LV apical territories. So this is the importance of cine imaging. Yeah. So what are the various sequences that can be used to assess for if you want to see the anatomical structures, the black blood imaging, functional assessment, bright blood, the flow and velocity quantification can be seen with phase contrast, and most importantly, tissue characterization using T1, T2 mapping and LGE and T2 star as well. How do we do a stress perfusion imaging in MRI? The patients are instructed to avoid tea, coffee 12 hours prior to the study, two separate lines are taken, one for adenosine, one for gadolinium instillation. What is an adequate stress test is when the heart rate is more than 10 per minute, or there is fall in blood pressure more than 20 mmHg systolic, diastolic 10, or the patient accounts for any of those symptoms of angina, heaviness or breathlessness. That is the end point of a stress imaging. We give administration of gadolinium half dose and then cine image, and rest perfusion with remaining gadolinium after 5 minutes to assess for LG after 10 minutes. So this is the standard protocol. This is just a repetition. We have tabulated it, that cine images can show stunned versus hibernating myocardium. Both will show hypokinesia. On stress, there can be defect. LG can be seen in LG is not seen in any of the viable. LG is less than 50%, LG is more than 50%, definitely the area is infarcted. So this is the tabulated form which we have discussed previously. So coming to the strengths and weaknesses. Strength is basically MRI can tell a difference between stunned versus hibernating. What is the infarct size, what is the amount of LG, what is the amount of scar tissue. There is no ionizing radiation involved. The results are easily reproducible. So those are the advantages. What is the drawback is if there are metallic implants, or if the patient is acutely ill, and there can be cost considerations. All those things are the weaknesses of the cardiac MRI for viability assessment. So one thing to understand here is that for LG CMR, the sensitivity is for viability assessment is maximum, which is 95% of all the tests that we have discussed. And for stress, dobutamine CMR is having higher specificity as compared to all of the imaging modalities that we have discussed. So that sums it up. For myocardial viability, we can have multiple methods of viability assessment. Each one of them has some of the drawbacks, and there are various ways to assess it. Thank you.